Let's get started. So, hello, my name is John Furman. Welcome to the EDS Awareness Educational Series webinar. We're honored to present another great webinar by Dr. Ann Maitland. This is actually the fourth that she's presented for us for mast cell activation. As in the past, these presentations will be recorded and they'll be posted on our site, and you'll also get an email with the link. So the slides will also be available to download in a PDF format so that you can look at those a little closer. And they'll be available at the site that you registered for this program. So before we get started and introduce a speaker, we'd like to give you an overview of our free EDS awareness programs. There'll be an opportunity for Q&A at the end of this presentation, and you're welcome to ask questions. All of the videos and the audios are turned off except for mine and Dr. Maitland. And to ask a question, you can chat, click on the chat panel. Only Dr. Maitland and myself will be seeing the chats, and she will respond verbally at the end of her presentation. So again, my name is John Furman. I manage the National EDS Awareness and Chronic Pain Partners nonprofit organization based in Cincinnati. Our mission is to connect, support, and educate patients, caregivers, and healthcare providers about Ehlers-Danlos syndromes and associated conditions. My daughter, Deanna, was diagnosed with hypermobile EDS in 2008, the same year my wife, Carol, passed away with breast cancer. I was a caregiver for my wife, who struggles with undiagnosed EDS for over 30 years. Deanna and I introduced these programs in 2012 to help EDSers form independent local support groups and spread EDS awareness and education in their local communities. We've been a sponsor for many EDS conferences and events over the last 8 years. We provide a variety of resources. So this is just kind of a general overview of our nonprofit activities. And I'm just going to go through a few specific ones to let you know some of the things that we're working on. So we've helped to start or support over 120 support groups to date. Many groups are given a free website with a link to the directory and map. Most groups are in the US, but we've helped others in Alaska, Australia, Canada, and the UK. We're very excited about a new program that we started. We have a monthly newsletter. We partner with Corinna Sturm, who's a journalist, and she's from Germany. She actually did an hour-and-a-half documentary on EDS with various people throughout the world. And she is writing and you can find that on our site, and I think we've done on May, June, July. So we're working on the one for August. The important thing is the webinars that we've been working on, and we received feedback from support group members that conferences provide valuable information so far, social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through our free EDS awareness educational series. We have over 100 webinars covering over 50 topics by 60 different presenters, and you can locate them by topic, location, especially click to the right, and you can get announcements for future webinars. So our members told us that someone needs to start training the doctors. So our physician, actually healthcare provider educational program was introduced in 2017. And we have 6 programs, and these are programs that are 724 available through the University of Wisconsin-Madison. You can get CMEs, CNEs, CEUs, for participating in these programs. So this isn't just for healthcare providers, but anyone interested in learning more about EDS are encouraged to view these presentations, whether or not they desire the certificates or not. We know that nurses spend more time with patients, so we recently organized a nurses advisory board, and we created a nurses educational program. We actually have 6 programs planned. 3 of those were introduced in January of 2020, and obviously with the latest pandemic, we haven't been able to get the other 3 up, but we will be getting those up soon. We recognize that it's very difficult for those with chronic pain like EDS to connect and manage support groups. So in May of 2019, EDS Awareness Month, we conducted a day-long presentation live streamed to existing and potential support group leaders. Topics included Facebook, advocacies, children's support groups, how to set up the support groups safely. Our guest was Mandy Harvey, who was award-winning singer, songwriter, inspirational speaker. So you're welcome to listen to her presentations and other presentations in this program. One promotion that we've done recently is a new book. It's called Disjointed. It's for parents or healthcare providers focusing on hypermobile EDS. And since this is a under-recognized, complex, multi-systemic disorder, there's a lot of issues that need to be addressed. So Diana created this presentation, edited it. It's 21 specialists and 6 resources. And Maitland provided the section on mast cell activation syndrome. So please check out that book. We have a review on our site, or you can go out to Amazon and get the book online. Dr. Maitland also provided us a link to an article she wrote related to misdiagnosis. And this is one topic that we hear too much about, misdiagnosis related to EDS and other disabilities. So this is a very interesting article. Also has some fantastic links to resources that you might be interested in checking out. So I also included in the package these links that you can check on when you download the slides. So that's my summary, and I wanted to give a general disclaimer, and we do this regularly just so people recognize that these presentations contain general information about EDS and related conditions, and they are presented by volunteers, so we do not pay anybody for these programs, and we are not selling anything. Maybe that book we did, but other than that, we're not out here to sell any products. What we want you to know that, if you're having problems right now, please call 911. Consult your doctor before you start, stop, or change any self-care medical treatment. So with that said, I'm really pleased to introduce our presenter this afternoon, Dr. Ann Maitland. She's going to talk about beyond allergies and particularly mast cell activation diseases. I won't go through the bio here, but basically she's a fellow at the American College of Allergy. Most recently, she wanted me to highlight that as of July 2021, this month, she'll be joining Dr. Bolognese and Dr. Rojo at the Mount Sinai South Nassau Hospital that's in New York. And we also have a presentation by Dr. Bolognese on our site if you're interested. This Dr. Bolognese focuses a lot on Chiari syndrome, so Dr. Ann Maitland's going to be helping with that. So with that said, and that introduction, I'd like to turn over the microphone and also the slides to Dr. Ann Maitland. Thank you for joining us.
Mr. Furman, as always, thank you for the kind introduction, and I'm delighted to talk about some new developments regarding understanding Ehlers-Danlos syndrome and its impact on the mast cell compartment. It's a crosstalk that has been going on for millennia. I'm seeing if I can open up my video. All right, so welcome to the wonderful world of mast cells. This is a solitary soldier that was identified back in the mid-1800s, and really the first job that was identified was nearly 100 years later when they found out about allergies being driven by one of the antibodies on these mast cells called the IgE, which we identify. So I don't have any disclosures, and we're going to be talking about what mast cells did before the allergy epidemic. Then we're going to be talking about how mast cells not only participate in allergic inflammation, but also plenty of non-allergic etiologies as well. And then we're going to talk about how do we diagnose individuals that have a single mast cell activation disorder, or they have more than one mast cell activation disorder called mast cell activation syndrome. So before the COVID pandemic, there was the allergy epidemic, which was the turn of the 20th century and the last 20 years. But before that, mast cells had plenty of jobs to do. And this is actually an interesting article. This is the 200th anniversary talking about the New England Journal of Medicine documenting the burden of disease. So prior to running water, prior to having the FDA control our food sources, extensive sanitation, people were really succumbing to infectious etiologies. And this is just some of the diseases that were listed back in the inaugural New England Journal of article almost more than 150 years ago. So in many ways, it is the mast cell that acts as the immune sentinel right below the surface area of the skin, the gut, the respiratory tract, the urogenital tract. And what it does, it has a plethora of receptors to recognize if there's been tissue injury and also what might be the usual suspect causing a problem. And then depending on what kind of damage is happening and who's doing the damage, the mast cells have the ability to selectively release different chemicals that can activate other immune cells, can properly release chemicals that can directly contain some of the pathogens. They have the ability to control blood flow with the release of histamine, VEGF, as well as platelet activating factor. And after the harm is contained, mast cells have the ability to coordinate tissue repair. And the way mast cells do this is based on the combination of receptors on their surface area that are engaged. Depending on whether or not this is another cell, whether it's a bacteria or another component of the immune system, whether it goes through any of these receptors, including IgE, which prior to the allergy epidemic was actually used to recognize parasites. the IgG receptor, which is what we hope is happening when we get our COVID vaccinations to kind of increase our protection. And then there are other receptors that are just used to recognize dangers to humans dating back several millennia. Depending on the combination, you can see there are lots of different of these chemicals that get released, and these chemicals are extremely potent. You don't want tryptase and chymase out there because it actually can chew up the connective tissue. Serotonin, you want it out there when you need it. And same thing for histamine, as well as heparin and all these growth factors. So it's really important that this mast cell releases chemicals when it's needed, and then to kind of dial down the release of these chemicals when homeostasis has been restored. So over the past 150 years, though, there have been a lot of advances in public health as well as in the medical arena. And this lists some of the observations or some of the milestones that a lot of folks in the healthcare field was key in reducing the burden of disease that was caused by infectious agents. And to narrow it down even more, they asked what are the top 12. And then if you look at it, half of them have to deal with how we recognize infectious agents. So the introduction of vaccines, the use of antimicrobials, including antibiotics and antivirals, the role of sanitation, understanding how germs communicate. This was very important for women at the turn of the last century on how to prevent the transmission of infections to the babies and the mothers upon delivery. I'm of course biased on how the role of the immune system plays in recognizing not only infectious agents, but tumor surveillance as well. And then also just how do infectious agents translate into causing damage down the road. So in this age where we saw such a significant improvement of infectious diseases, you can see by the reduction of rheumatic fever and hepatitis and tuberculosis, as well as measles, mumps, and rubella. And yes, we have a little bit of a blip here, and this is actually probably during the AIDS epidemic. But at the same time, we started seeing a huge increase of hypersensitivity disorders, whether they're immediate hypersensitivity disorders like asthma, food allergy, rhinitis, hives, but also delayed hypersensitivity reactions, including inflammatory bowel disease, type 1 diabetes, and immune-mediated neuropathies like multiple sclerosis. And in many ways, this ties back to our borders and what our environment is doing and how we are responding to it. And not everybody responds the same way, and I'll get back to that. But literally, by the turn of the 21st century, all of these mast cell activation disorders were impacting at least 1 out of 2 of us to a certain degree. And a lot of people ask, well, why is that? Are we too clean? I think that's part of the answer. We've had a dramatic change in our food supplies. We've had a dramatic change in our living environments where when I was growing up as a child in New York City, I would spend maybe half of my time indoors. Now the average American spends 90% indoors of either a building, a home, means of transportation. We've also seen a huge increase in obesity, which is also impacts the immune system, and it can cause you to have a more hypersensitivity or allergic-like phenomena. We have also seen climate change and how we see an increased counts of pollen and mold and also increased air pollution. All of this is impacting our skin, our respiratory tract, and our gut. So in many ways, it is our habits that have led to what was initially labeled the allergy epidemic. By the late 1990s, we were seeing a huge increase in asthma. Allergic rhinitis was affecting 1 out of 3 children and 1 out of 4 adults. And then I think this is a wonderful article in the New York Times talking about the first child that I met who had airborne anaphylaxis to milk, and that was in the mid-1980s. So already by the end of the 20th century, we were seeing a huge burden in allergen-triggered mast cell activation disorders. And this is just to give you a kind of like a summary report of what we're dealing with now. We have so many children and adults that are being impacted by inflammation affecting the upper airway, causing postnasal drip, increased susceptibility to infections. We're having lower airway involvement. We actually don't even know how many individuals are impacted by asthma because we don't we don't screen for asthma. We wait for you to have an exacerbation and then try to control it the best we can. So seeing an increased risk of itchy red rashes to the point that 1 out of 5 of us will have either hives or swelling. We have increased risk of food allergies. And then the latest data, as far as in 2015, 1 out of 50 individuals in America have been treated for anaphylaxis. So there's a huge burden of allergic disorders. And when you have these type of symptoms and you go to a doctor, one of the first things they're going to do is check for allergies or allergen-triggered mast cell activation. They can either do this by skin testing, either to airborne foods or some medications, or they can do a blood test. Either way, it's really only focusing on one form of hypersensitivity disorders. One form of hypersensitivity disorders that includes going through this receptor only. But there are a lot of other receptors on the mast cells that are trying to figure out what they're encountering when they detect tissue damage. So just to give you an idea of the different receptors that are available, which are going to be very important to understand why there's sensitivities to certain medications or foods, or why you may have a typical atypical reaction to infectious agents. So there is a receptor, which I just call the MERG receptor for short, that has increased susceptibility to mast cell degranulation when you take a fluoroquinolone like levofloxacin or Avelox. It also has the ability to be sensitive to medications like vancomycin. Mast cells also have opioid receptors, so this is why, you know, when you're taking medications to reduce your pain, you might accidentally cause the mast cells to release chemicals, and it would make the analgesic effect reduce because you're having competing actions going through the mast cell as well. And then what I think is going to be important to really note is that the mast cell has the ability to recognize pathogens, even coronavirus. And this might be really important in either minimizing an adverse reaction to the COVID vaccine, or also trying to avoid the risk of developing long-term hauler syndrome. So there's active research going on, trying to understand the initial damage or interactions with certain pathogens, including the coronavirus. So you can see that there are many ways that mast cells can be activated besides the allergy, quote unquote, allergy receptor. And just to give you an idea of different ways one can develop anaphylaxis. So this is what most practitioners are familiar with. This was 1 or 2 lectures back in the first year of medical school. It could be having food allergies to pollen, mold, or animal dander, for instance, stinging insect allergy. And these are the chemicals that typically get released. And these are the type of symptoms that we're very familiar with. You can have back pain, you can have gastrointestinal distress, or you might have a drop of your blood pressure, flushing, or itch. But look what happens if the mast cell is activated in conjunction with other components of the immune system, either T cells or macrophages, or with their blood-borne cousin basophils. Not only do you may have the release of histamine and tryptase, you may have the release of these chemicals, especially interleukin-6 and tumor necrosis factor, which will cause not only allergic-like reactions, but also cause fevers and chills, fatigue. And if this keeps on reoccurring, you may have not only a kind of like an infectious syndrome going on, but you're also having allergic phenomena as well. So in 2010, the World Health Organization mast cell working group decided, instead of just talking about how mast cells might be triggered, let's see if whether or not mast cells are actually part or the prime reason you might be having hypersensitivity reactions. So they put forth the criteria to describe the diagnosis of mast cell activation syndrome, recognizing that they're both immunologic and non-immunologic triggers for mast cell degranulation. And I want to show you that this is an individual that actually has hives and swelling when they go into the cold. This is also can happen with vibration and delayed pressure urticaria. So the diagnosis of mast cell activation syndrome really boils down to, do you have signs or symptoms in at least 2 organ systems? You know, are you having headache disorders and gastrointestinal distress? Are you having asthma-like symptoms and the diagnosis of interstitial cystitis? If you have at least 2 of these conditions, you should evaluate your increased susceptibility to having hypersensitivity disorders, which will be important to kind of not only keep your symptoms under control, but prevent you from having exacerbations, so that you can sleep better, you're able to exercise, you're able to tolerate more foods without having hypersensitivity reactions. Then, do you get better with medications? Many of them are over the counter, including histamine blockers such as famotidine, which is Pepcid, diphenhydramine, which is Benadryl, or Allegra or Claritin, which are second generation histamine blockers. And then after you get a good story of your symptoms and whether or not you're getting any better, do you have test results? And I find that this is probably the hardest thing for most of the patients who may have suspected mast cell disorders. This is the most difficult and challenging thing to obtain due to the lack of access to appropriate testing in many centers across this country. So one of the first papers that introduced the idea of mast cell activation syndrome is a joint effort. And then one thing I would have to say that it's really important for everyone who has either are impacted by these hypersensitivity disorders or caring for somebody who has hypersensitivity disorders. It is a joint effort that's going on with primary care who's working, in this case, with gastroenterologists and allergy immunology specialists. So they actually went into a irritable bowel syndrome clinic. And if anyone has been dealing with irritable bowel, meaning that they can't figure out why you're having alternating diarrhea, constipation, increased hypersensitivity reactions, they end up putting you on a FODMAP diet, maybe putting you on medications that not necessarily targeting the mast cells. So what they did was a prospective study, and they simply asked people who were coming into the IBS clinic, do you have any of the symptoms that are worrisome from mast cells misbehaving outside of the gastrointestinal tract? And interestingly enough, within a short amount of time, they were able to identify 18 individuals. And besides gastrointestinal distress, they were complaining about skin symptoms, they were complaining about neurocognitive issues or headache disorders. Actually, 3 of them had been treated for anaphylaxis, and there was a significant number who were having either upper or lower airway inflammation. So by simply asking for questions outside of the area of specialty that you're dealing with, you might be able to identify somebody who has a mast cell activation syndrome. The next thing is, do you have any data that supports that your mast cells are misbehaving? Now, as I said before, you can see there are plenty of chemicals that the mast cells release. But when it comes to the treatment of mast cell disorders, the medications are really targeting not necessarily growth factors, not necessarily cytokines. It's targeting hypersensitivity disorders that are being mediated by prostaglandins, leukotrienes, histamine, or these enzymes. So the gold standard to identify somebody who has a mast cell disorder is to get a baseline serum tryptase. Just, go in, get evaluated, have that test. And then you should also have a script. So the next time you have a hypersensitivity reaction or flare up, you can either go to the emergency department, the urgent care, and say, look, my doctor has ordered this. Can you please get this while you're treating me? And if it goes up a certain amount, that is actually diagnostic for mast cell activation syndrome. You can also do 24-hour urine collections for methylhistamines or the leukotriene or prostaglandin metabolites as well. But I also want you to remember that mast cells are not a blood-borne cell. These cells, there are less than 1,000 progenitor mast cells that circulate around the adult body at a given time. And so these cells are long-lived in the tissue. So by checking a tryptase or a histamine or prostaglandin, we're looking for surrogate markers for mast cell activation that's happening in the skin. But interestingly enough, it was these markers that showed that these individuals were having mast cells contributing to their quote-unquote irritable bowel syndrome. And by doing that, they were able to identify medications that targeted either the histamine or the leukotrienes or the prostaglandins to help their symptoms come under better control. There have been other markers that have been looked at, including heparin and chromogranin A, but there's absolutely no data showing that if you use medications like histamine blockers or leukotriene blockers, where your mast cell disorder was identified by either heparin or chromogranin A, that those medications will be helpful. And I'll get into more detail regarding what kind of planning you should have once you're diagnosed with mast cell activation syndrome. So remembering that the mast cells are a tissue-based cell, it's important to, if you've had an endoscopy or a colonoscopy or a skin biopsy, pathologists don't typically stain for mast cells. So a simple note from the doctor that's performing the procedure to the pathologist is, can you put on a stain that identifies mast cells? And what I would like you to remember is mast cells, normal mast cells, are circular and by themselves. They're not spindle shaped, they're not hanging out together, and they're certainly not clustered. So if you see, or the pathologist sees, spindle shaped cells, small clusters of mast cells, or large clusters, I'd be concerned about a mast cell activation syndrome. And the most recent data, which was very exciting, trying to identify what might be a potential marker for hypermobile type Ehlers-Danlos syndrome, was actually put forth by Jonathan Lyons and Joshua Milner back in 2014. And they actually identified the gene in 2016. And they found that individuals had an increased number of this gene that's only found in mast cells, and that's called hyperalpha tryptase. And interestingly enough, at least in the Caucasian population, we know that 5 to 7% of the population have hyperalpha tryptase. So there seems to have been some type of evolutionary advantage to having more of this enzyme, or whatever travels with this enzyme, in a large segment of the population before the world changed on a dime nearly 30, 40 years ago. But what's interesting with this multiplication of this tryptase gene, this protease, which Dr. Theoharides refers to as a meat tenderizer, is these individuals who had variable penetration. By the way, this is an autosomal dominant inherited gene, which you can detect in people who have a tryptase as low as 7. Meaning that both one of the parents has it, and then the possibility with children, one of the children is a 50% chance that the children will also inherit this. It is associated with connective tissue disorders that resemble hypermobile type Ehlers-Danlos syndrome and hypermobile spectrum disorder. It's associated with autonomic dysfunction, and it's also associated with mast cell disorders involving the skin as well as the gastrointestinal tract. So here you have a trifecta of disabling disorders associated with a single mutation that's only found in a gene in mast cells. And I just wanted to emphasize again, a recent study, and this is really hot off the presses, this just came out in a few months ago, where they went back and looked at individuals that don't have mast cell activation syndrome, that do have mast cell activation syndrome, but not the multiplication of that tryptase gene, and then individuals that had hyperalpha tryptasemia. And what you're seeing is in individuals that had mast cell disorders, but not the hyperalpha tryptasemia, there was not too much of a difference. You can count them, you can see the numbers aren't the same, but when you see individuals that had hyperalpha tryptasemia, you saw more cells and you saw more of these cells clustering, suggesting that these cells are chronically activated, but at a lower level. So simply by looking at the tryptase, and again, if you see a serum tryptase of 7 or higher, it is worth getting an assessment, which is just a cheek swab to see whether or not you may have inherited this multiplication of the tryptase gene. And then it's important to screen for those 3 disorders. Screen for the mast cell activation syndrome, screen for the possibility of having a connective tissue disorder, and also screen for the possibility of having autonomic dysfunction such as postural orthostatic tachycardia syndrome, or POTS. And this is just the data showing that compared to the controls, individuals that had hyperalpha tryptasemia had increased number of clusters compared to ones that had mast cell activation syndrome without having that multiplication of that enzyme and compared to the controls. So let's then talk about how to round out the diagnosis. And again, do you get better with medications that target the mast cells? And understand there are a lot of medications out there, such as corticosteroids, whether you're taking them as a nasal preparation, inhaling them, swallowing it as a pill, or using it as a suppository. Steroids don't count. What we're trying to figure out, because steroids have the ability to impact other cell populations besides mast cells and their blood-borne cousin basophils. We're looking for individuals that get better with histamine receptor blockers, histamine receptor 2 blockers, tricyclic agents such as doxepin and nortriptyline, which interestingly enough, after psychiatrists stop using it for mood disorders, gastroenterologists use it for IBS, neurologists use it for migraines and pain syndromes, and allergy immunology specialists use it for people who have chronic hives or itch. Then you also have leukotriene antagonists. This has to be done with a specialist who can recognize the balance between aspirin causing an allergic reaction as opposed to suppressing the mast cells. And then you have two mast cell stabilizers, including ketotifen or cromolyn. For those that actually have a clonal disorder where the number of mast cells are really replicating, such as systemic mastocytosis, there are other agents that can be used. There's been some talk about the using of imatinib or avapritinib. This is really reserved for individuals where the mast cells have gone so awry, they're starting to replace and disrupt the architecture of other organ systems. And really, this is a joint effort between you, your primary care, and a hematologist oncology specialist. So once you get the diagnosis of mast cell activation syndrome, again, it's important to make sure that mast cell disruption is not going along with or mimicking potential other comorbid disorders. We have individuals that have POTS. So it's important to say, if you have POTS, you should probably get screened for mast cell dysfunction. You have individuals that get diagnosed with fibromyalgia, which is a chronic pain syndrome, and understand in the respiratory tract, the skin, the gut, the brain, mast cells and nerve fibers talk all the time. You have single organ involvement in the gut with different types of food intolerances, whether it's eosinophilic esophagitis, gastroesophageal reflux disease, gluten enteropathy, which isn't necessarily celiac diagnosed. And then there are also some neuroendocrine tumors as well. And then these are some other conditions to be considered, but I really like to emphasize the relationship between the connective tissue disorders, knowing that mast cells have the ability to initiate tissue remodeling after harm occurs. So why you want to get the identity of what might be causing the mast cells to misbehave is there's going to be different treatments. As I said before, if you had a clonal mast cell disorder like systemic mastocytosis, you may have to start using an agent that actually just knocks off your mast cells. But they have major side effects where it really needs to be monitored under the care of a hematologist oncologist who has expertise in that arena. And gratefully, the Mastocytosis Society has partnered with several organizations, including in New York, California, National Institutes of Health down in Maryland, DC area, where these are centers of excellence trying to identify mast cell specialists who have multidisciplines to address these clonal mast cell disorders. You have the hyperalpha tryptase, which I've already talked about, but I have to tell you the lion's share of mast cell activation disorders and mast cell activation syndrome are individuals where the mast cells are being good soldiers but following bad orders. For instance, instead of having IgE that recognizes trypanosomiasis or Borrelia, it's going after pollen or mold. So this is people who have allergen-driven mast cell dysfunction or allergies. You have some individuals where they end up having hives of gastrointestinal distress, and the mast cells are trying to tell you something's wrong elsewhere, whether or not you might have an undiagnosed inflammatory disorder such as Crohn's disease or sarcoidosis or a brewing lymphoid tumor. So it's really important to make sure you're not missing anything regarding a mast cell responding to another danger, because mast cells are not only involved with responding to infectious agents, they're also responsible for tumor surveillance as well. You have individuals that have physical urticarias, and I have to say that this is very prominent in individuals that have connective tissue disorders like Ehlers-Danlos syndrome. And I would encourage any practitioner, the person that has hypermobile type Ehlers-Danlos syndrome is having mast cell dysfunction as well, just strike their skin. Because if it flares up, that is a physical urticaria called dermatographism, or the ability to write on the skin. And then just like any other cell population, you can actually develop antibodies against the mast cells. And here it's called chronic immune urticaria, meaning having recurrent itch, flushing, or redness in the skin. But this literally can happen anywhere that autoantibody is running around. This is some of the testing that I typically do, and I'm not going to go through it, but needless to say, a lot of these tests, by the time I evaluate patients, have been done is negative. The two things that I find not to be done very often is to see whether or not this person may have a primary immune deficiency, or they've not been screened for a connective tissue disorder or neuropathy such as POTS. This is one I wanted to show you regarding the physical urticarias called spontaneous inducible urticarias. So this is dermatographism, where you just strike the skin and it pops up. This is an individual where they had an ice pack put on their leg, and you take off the ice pack a few minutes later and they break up with hives. And then this is a woman who has what's called delayed pressure urticaria. And women or men can experience this if they have a tight fitting garment, such as a belt or waistband, as well as bra strap. But this also can happen if you're carrying heavy bags on your arm or have a tight wristband as well. So just as a brief intermission, because sometimes I can get a little chatty, I just want to show you that this is the sign of individuals that have Ehlers-Danlos syndrome. They consider themselves zebras, and a group of zebras are called dazzles. So this is a dazzle having joy playing in the mud. So that's kind of leads me into, let's talk about Ehlers-Danlos syndrome and how I, as an allergy immunology specialist, ended up working with patients and practitioners who have who are becoming more aware of how joint hypermobility is associated with lots of other issues, including chronic pain syndromes, chronic fatigue, having polycystic ovarian syndrome, or possibly thyroid disorders, dealing with orthostatic intolerance in POTS, having pelvic floor dysfunction. All of this is associated with chronic injury, and it's just a question of what is the target of that injury. And then Marco Castori, who was a dermatologist back in 2012, speculated that individuals that were able to flex their thumb to their forearm had immune dysregulation, but he didn't speculate what cell population was responsible for it. But this is an electron micrograph showing a mast cell having these large granules that are just loaded with chemical mediators that can modify the environment. And again, you really don't want these mediators out there unless you really need them, like fighting off a major infection. So a couple of the reports that started coming out in 2012 and 2013, this is Peter Vadas, who is an allergy immunology specialist up in Canada, had noted that individuals that had Ehlers-Danlos syndrome seemed to also be dealing with mast cell activation syndrome and postural orthostatic tachycardia syndrome. You can also see that this is a study that I had done with two now practicing allergy immunology specialists, but I also saw a lot of individuals nearly 10 years ago who were complaining of hypersensitivity disorders, and allergy testing just wasn't giving an answer. And then if you just looked at the person, they had wonderful skin, they were able to be very flexible, they were either yoga enthusiasts or dancers or cheerleaders or swimmers, and extremely accomplished in both curricular and extracurricular activities, until something happened that kind of knocked the wheels off the bus. To screen for Ehlers-Danlos, I've decided to just put the two criteria up. So to the right is what the English criteria use for Dr. Ehlers and Dr. Danlos, where you look for evidence of hypermobility. And if you have one of those five, it suggests that you should be screened further for the possibility of Ehlers-Danlos syndrome or hypermobile spectrum disorder. This is the French criteria. And literally, if you just look to see if you've been treated for joint problems for more than 3 months, you're dealing with chronic fatigue, you find that you're bumping into doors or end tables and having problems with your balance. If you've been treated for subluxations or dislocations, skin fragility, you have one of these positive signs, especially the 5-point, where you might have your fingers bending back, your elbows overextend, and you're able to palm the floor, is also a positive point. Have you ever been treated for gastroesophageal reflux disease? Do you have problems with easy bruising? Or you have sound sensitivity? Here in the US, it's not unusual for people that have sound sensitivity, can't stand other people chewing near them, or can't stand whispering, or the air conditioning coming on. If you have 5 of these, it is very suggestive that you have Ehlers-Danlos syndrome. And if you have Ehlers-Danlos syndrome, mast cell activation disorder may not be too far away. Now, the screen for orthostatic tachycardia syndrome, there's a tilt table, but I have to say that I'm really kind of reluctant to recommend tilt table because individuals that have a connective tissue disorder, and if they have cervical spine involvement, they can get really sick if they do that. There's a very innocuous way where you just measure your blood pressure and your pulse standing, sitting, and lying down. And if there's a dramatic difference of 30 to 40 beats per minute, depending on pediatric or adults, from lying down to standing, or you have a drop in blood pressure, that's very suggestive of you having the diagnosis of POTS. Also, you can just take a look at the feet. And this is a person who is just got up, and this is what happens when she stands for a long time. You have this venous pulling. So all of this is actually representative of someone who may also have autonomic dysfunction. And this is what I had to learn when I started seeing patients come through with hypersensitivity disorders and their allergies were not answering it. Again, I want to emphasize there are lots of different ways that mast cells can release their chemicals. Sometimes they do wholesale degranulation. Sometimes they just have selective uptick of secretion of certain factors, whether or not they're growth factors, such as what interleukin-6 is doing in individuals that have coronavirus exposure or COVID. You have certain medications that will modify mast cell function as well. There are peptides that are coming from other neuroendocrine cells or the nerve cells themselves. And then, it's also outdoor exposures, whether you're talking chemicals such as mercury or naturally occurring substances that come from fungi or stinging insects or caterpillars or frogs and certain viruses as well. And the reason why you want to do that is once you get the diagnosis, that's one thing. Treatment is based on what is causing the mast cells to misbehave. So a lot of the individuals that I'm caring for at this time usually have a tendency to have a combination of treatments based on what we were able to find causing their mast cells to misbehave. Do they have evidence of allergen-specific IgE to animal dander or to fish or eggs or milk? There are avoidance measures and then possibly desensitization, which you can do with an allergy immunology specialist. There are medications that target the mast cells. And generally speaking, if I'm going to do a combination of a histamine blocker or leukotriene blocker, usually you should notice improvement if it's just this component contributing to mast cell dysfunction. You should notice an improvement within 2 to 3 weeks. Keeping taking this medication and not having significant improvement suggests that something else is causing the mast cells to misbehave. And I have to tell you, most individuals, I have found evidence of a primary immune deficiency, such as not sufficient protection against measles or coronavirus or strep or whooping cough. Some individuals have a chronic infection, and understand typically, if you have an intact immune system, you should be able to respond to traditional treatments that go after Lyme or Borrelia or go after bacterial infections. So if you're having issues with not being able to control these infections, I would be very suspicious of having lacking a component in the immune system as well. And then when you have ongoing tissue damage, whether it's from infections, whether it's from allergen-driven mast cell activation, or from developing an autoimmune phenomena, you can then end up with chronic tissue damage that then translates into classic autoimmune disorders like rheumatoid arthritis or Sjogren's disease. So when it comes to treatment, also, besides medications and avoidance measures, there is some interesting data that comes out of the French EDS groups showing that if you use tailored compression garments, the use of acupuncture, acupressure, and also targeted physical therapy for proprioception, you can improve the POTS. And by improving the POTS, you can actually see that the mast cells start to stand down as well. I really want to emphasize the importance of screening for mast cell activation syndrome before you have surgery or a procedure like prolotherapy, or you're going to go for surgical procedures such as taking out your gallbladder or having an injection in your back. It's important to know that there are medications that are better tolerated in individuals that have mast cell activation syndrome as opposed to those that are not well tolerated. If you have, for instance, neurosurgery and you don't know you have mast cell activation syndrome, it's going to be much harder for you to feel better with opioids, if not actually these agents causing you to have direct mast cell activation. You can also see that there's certain induction agents for anesthesia that may cause direct mast cell activation, making it harder for you to fall asleep or stay asleep during a surgical procedure. And then also there's certain anesthetics that might be more problematic as well. And also the latest issue right now is whether or not individuals are having intolerances to vaccines, such as the emergency authorization use of the COVID vaccines, and also more traditional vaccines like the strep vaccine, the one for varicella, as well as the one for whooping cough. So I wanted to just briefly go over a case report, and then I will open up for some questions. These are the various symptoms to look for to see whether or not somebody may be at risk for mast cell activation syndrome. This was a little girl that I had met a few years ago. Her name was Sarah. I have changed some of the details in order to respect her identity. And this is just a Shutterstock picture of a little girl doing gymnastics, but it's not unusual to find someone who has a hypermobility issue may also be having issues with anxiety. This is or neurocognitive issues or learning issues. And Sarah had manifested both mast cell driven inflammation of her upper airway. She required OT and PT for some sensory issues and required cognitive behavioral therapy because she was susceptible to being anxious under certain circumstances. So here's already some red flags suggesting that there might be miscommunication of the connective tissue impacting the mast cells. At her 12th birthday, she had a bad respiratory infection, and she also had the onset of menses. And after the infection and during this period of time, that's when she started becoming fatigued. She started having nausea and abdominal pain no matter whenever she ate any foods. And they tried various restrictions of diets. They tried various agents targeting the mast cell compartment. She didn't get any better. You can imagine she was evaluated at least 3 children's hospitals, and all of the tests at each single hospital was normal. X-rays were normal, CAT scans were normal, endoscopy examinations were normal. But remember, when you do an endoscopy, if you don't ask for mast cells, you're not going to see them. CAT scans or X-rays won't be helpful unless you bend the person to see whether or not they may have issues with their cervical spine. And then mast cells are not found in the blood. So if you're going to do a blood test, you either have to look for an increase in its cousin, the basophils, or an elevated serum IG level or allergen-specific IG tests. So when you say normal blood tests, I want to be a little bit more specific on what are you talking about. So at one point in time, she was getting really bad, and they decided, the parents were frustrated, and her pain was just not controllable. So she actually was enrolled in one of the amplified pain programs. And despite a 4-week stay, there was no alleviation of her pain. They even tried NG tubes, didn't work as well. So they started entertaining that this was all in her head, and was going to label her with a psychiatric diagnosis such as a conversion disorder. Again, she had repeated allergy testing. IG was not significantly elevated except for directed against pollen. And again, for now close to 2 years, she was waking up in pain. She was dealing with chronic nausea and fatigue. You can imagine that she was missing a lot of time from school, and schools are actually quite cognizant now and push back if you do not have a good excuse why she's not able to participate in school. But interestingly enough, when she stayed home and was able to recover, she was very interested in learning. So you can imagine that the pediatrician was getting frustrated. The school was getting frustrated. She was having an increased number of absences. Neurologist diagnosed her with migraine, which means we're not finding anything. So this must be just your blood flow going and coming inappropriately. She was diagnosed with POTS. So here's a neurologist who actually decided to stand her up, check her pulse and her blood pressure. Her pulse went up 40 beats per minute, and her systolic blood pressure went down by 10. And he suspected joint hypermobility, but never further evaluated it as well. She went to another pediatric gastroenterologist who tried various formulas and nasogastric tubes, and every time she ate, she had pain. So she was evaluated for median arcular ligament syndrome. It was positive. She did get the procedure, but it only offered her temporary relief and she relapsed again. So she ended up, after a endoscopy, she ended up at a hospital where the team thought that she had what's called food aversion disorder. They didn't take into account that she had already had nasogastric tubes and that caused pain. They called a psychiatry consult, basically ignoring the data that was done at other children's hospitals, and basically force-fed her for 3 days in soft restraints in order to see whether or not the pain came under control. And so this child ended up having quite a bit of trauma just from hospitalization, where well-intended practitioners ended up doing more harm than good. So after 3 days of this, and she had no change in her pain, no gain in her weight, she was discharged home with this diagnosis after having an NG tube placed 3 times daily with soft restraints on. One test that they failed to acknowledge and understand that this was in 2014, she had a tryptase of 11.9. And subsequent evaluation found out that she, her sister, and one of the parents also had a duplication of the tryptase gene. This led her to a neurologist who was appreciative of her connective tissue disorder, further evaluated for her. Also, she had dimples on her back, which no one commented on. It turned out she had occult tethered cord syndrome, successfully underwent the surgery to release her tethered cord, and within a couple of days, she was pain-free and nausea-free. So it's really important that you do just a few more tests, ask a few more questions about other organ systems, specifically look at the tryptase. And I want to emphasize here, we don't know what a normal tryptase is. It's really important to get serial measurements and then also take a look at the tissue to see whether or not there's an abnormality in the mast cells. If there's an abnormality in the mast cells, it's important to figure out what might be causing the mast cells to misbehave. Are they broken within, such as hyperalpha-tryptasemia or mastocytosis, or are they being driven by outside forces such as allergens, another undiagnosed disorder such as POTS, or a connective tissue disorder? And this is just showing that regarding, I just wanted to give you an example of the dimple. This is not Sarah, but another patient. But again, if you have a suspicion of gastrointestinal distress, any evidence of urinary abnormalities, she should be evaluated by a practitioner who's knowledgeable about occult tethered cord syndrome. So what's the delay in patients getting the diagnosis of mast cell activation syndrome or disorders that run with it, such as autonomic dysfunction and connective tissue disorders? Well, patients might not know that they have issues until they're really bad to bring up to their practitioner. Primary care, for the most part, if they had any contact with allergy immunology specialists or hematology oncology specialists that knew about mast cells, it was 1 or 2 lectures a few moons ago. And then when it comes to specialists, a lot of specialists don't know about tryptase or how to measure the leukotriene or methylhistamine, which have to be kept cold. And so we have more work to do regarding spot testing that may be helpful to identify individuals that have mast cell activation disorder. And I just want to let you know that this is not a new problem. This is a woman that was portrayed almost 100 years ago who had gastrointestinal distress and was discharged again with a conversion disorder, and basically ended up with quote unquote Christian Scientists. And no bias, but this is what Dr. Peabody had mentioned, where he says, we can't forget the patient's story. And in Sarah's case, just because you don't measure it doesn't mean it doesn't exist. And unfortunately, our healthcare system has too many pressures on both the patients and the practitioners in order to allow a more thoughtful process on what might be going on in individuals that don't have abnormalities in the normal battery of tests. I just wanted to show you that this is more recent. This is a story of Laura Hillenbrand that caught my eye with this story in 2014, who's been dealing with chronic fatigue syndrome. She also has evidence of she was diagnosed with hypermobility, but that wasn't further worked out. And if you have the autonomic dysfunction and the connective tissue disorder, it's important to look for mast cell dysfunction. And I have to tell you, POTS is now getting more attention because of all the individuals that have had COVID and recover, but then relapse with this long hauler syndrome. And then this is just from the French group saying that when it comes to the diagnosis of Ehlers-Danlos syndrome, you can have up to over 20 years before you get a proper diagnosis. And really all you have to do is bend people, look at their skin, ask them some questions about what they've been treated for in the past, and you'll be able to identify Ehlers-Danlos syndrome. And then this is just emphasizing, again, individuals who've had diagnosed with mast cell activation syndrome who waited years before they got a diagnosis and still are on quite a bit of medications, including this young lady who's on omalizumab, which is Xolair, and IVIG to get her symptoms under control. So for an ounce of prevention, it's important to think about if you're going to see a doctor because you're having joint problems, the EDS, think about autonomic dysfunction and mast cell disorders. People who have come to me for mast cell disorders, I evaluate them for the EDS and the autonomic dysfunction. So, and these are, again, 3 simple things without blood tests to identify whether or not that's a problem. When it comes to personalized medicine, it's really important to figure out why you're having these symptoms. If it's MCAS, it's important. Don't think mast cell disorders run by themselves. It's important to evaluate if you are having issues that are beyond rashes, but this again points to mast cell dysfunction as well. This is the questionnaire, and I'm just showing you, but this is the questionnaire that I use to try to identify individuals that have mast cell activation syndrome. If you check symptoms in any one of these organ systems, if 2 or more organ systems, you're going to get an evaluation for mast cell dysfunction. And then this is just to remind you, when it comes to the diagnosis of mast cell activation syndrome, what are your symptoms? Do you get better with medications that target mast cells? And what positive lab tests that you have? There are the treatments. And this is my rule of thumb. It's important that when it comes to goals of care, we're trying to prevent chronic or disabling symptoms. We're trying to get you better to normal function step by step. You didn't get there overnight. It's not going to happen overnight, but we've had some significant success once we identify the connection between these 3. Optimize the pharmacotherapy, make sure you're minimizing side effects, but you're actually getting better. Taking histamine blockers, they're for the most part safe. But if they're not really helping you, I think you need to kind of evaluate what else is going on. We're trying to help you maintain normal activities, prevent you from going into the emergency department because for the most part, they don't know how to help you. And then once you have these addressed, are we really meeting your expectations regarding the diagnosis and care? And I will end there and happy to address questions.
Well, thank you, Ann. That was fantastic, Dr. Maitland. Covered many areas that I know we're all very interested in learning more about. So there are a number of questions under the Q&A and chat,
Yes.
and feel free to check those out.
So I'm going to address the first question regarding the specific number of mast cells in the gastrointestinal tract that be worrisome for mast cell activation syndrome. So I would have to say we're still working on the data, but I usually do a cutoff of 20 to 25 mast cells per high power field. But again, you don't just want to count. You also want to see, are they spindle shaped? Are they clustering? Are you finding the mast cells are next to each other? Do they have upregulation of activation markers? So there's something besides just counting that's important to see whether or not, and it's a very simple test to see whether or not you have mast cells misbehaving. Once you see that the mast cells are misbehaving though, it's really important to try to figure out why. Do they have a connective tissue disorder? Do they have undiagnosed neuropathy? Did they check for a possible immunodeficiency? So it's, again, are your mast cells misbehaving, and then why? The next question, if a person with a diagnosis of HEDS has a fracture that is having difficulty healing and one suspects mast cell activation disorder, how would you treat the distal site in the blood, for instance, a fracture in the foot with mast cell stabilizers? Specifically, if one has convinced an MD to check for the CD117 stain in the upper endoscopy, and it shows an increased number of mast cells, from 26 to 30 per high power field, is there a way to treat a site of bone healing? So here's the thing. We have to kind of separate the jobs of the mast cells here. So I've not seen fractures heal with using histamine blockers or leukotriene blockers. It may allow you to tolerate other interventions that will help improve the blood flow. Mast cells do control blood flow. Those medications don't necessarily improve the release of heparin or the release of platelet activator in a coordinated fashion. And also, if there's difficulty healing, I would also make sure that you don't have what's called soft bone syndrome. It's important to make sure that you don't have a low alkaline phosphatase called hypophosphatasia, because these individuals are at increased risk for having fractures not heal well. And there's a real straightforward treatment if that is the case. But again, just looking for mast cell dysfunction is not going to be sufficient in order to help that bone heal. It's kind of like that police officer who shows up to a fire. He helps get people out of the building, but he doesn't necessarily know how to put out the fire. Mast cells have a certain job to do. And after they do their job, which means, can I contain the problem? And do I need help? And then what help do I need? You want to make sure that is a balanced response to turn on the inflammation and the balanced response to turn on the coordination of the healing, and then turn it off. You don't want too much of those factors like the tryptase and the enzymes chewing things up, because that will interfere with your healing as well. So there was a question about what is the best practitioner to test for mast cell activation syndrome. Well, first of all, if you're not a practitioner yourself, it's important to kind of align yourself with a general practitioner, whether this is for a child, such as a pediatrician or family medicine, who's willing to learn and work with you to see whether or not mast cell dysfunction is happening. I would have to say, if you want an idea of who is knowledgeable about mast cell activation syndrome in your community, you can go to the Mastocytosis Society, which is tmsforacure.org, and they actually list practitioners per state who have knowledge, whether it's a hematologist oncologist or whether or not it is an allergy immunology specialist. But there's also some very motivated general practitioners who might be also helpful. For instance, here in New York, there are 3 lovely rheumatologists and gastroenterologists who know how to do the screen. And once you do the screen and get the diagnosis, management typically falls with someone who takes care of patients, because by definition, this is a chronic disorder. It shouldn't be chronically disabling, but it is a chronic disorder. So that trifecta, it was actually a really interesting article in that's actually found on the EDS Society, talking about 3 disabling conditions, one gene, and that's the hyperalpha-tryptacemia, and how having this trifecta puts an increased demand on your body to do things, interferes with metabolism. So it would be important to understand why your mast cells are misbehaving, because hyperalpha-tryptacemia does not exclude you having problems with other issues that will drive your mast cells to misbehave. It would be important to check for whether or not you might need a coordinated effort. For instance, in addition to medications that target the mast cell compartment, we also use, we work with physical medicine and rehab, as well as physical therapists and occupational therapists and acupuncturists, to kind of improve the communication between the connective tissue and the nervous system, which will also allow the mast cells to stay down. So, and also it'd be important, you know, we find people with the trifecta end up having sleep disorders for various reasons. Having a sleep disorder puts more stress on your metabolism, which will also interfere with your ability to manage sugar levels. So it really is, you have to kind of go through each organ system to make sure it's the care is well coordinated and that you have a team in place. So I often tell individuals that have the trifecta, you're kind of like a Maserati trying to drive on the streets of New York City with all its bumps and pitfalls and hard turns. So, and when something happens to one part, the rest of the car is going to be impacted. So it's really important that you're the driver of that car, you're working with a general practitioner who's going to be coordinating and monitoring the care. And I have to tell you, the individuals that have done the best up to this point are individuals who have a general practitioner who's working with the other specialists that are involved in your care. They have a good perspective about what's going on. And I have to tell you, this is why I'm very excited about the efforts that are coming together at South Nassau Community Hospital at Mount Sinai. You're going to have 3 experts under one roof, which will have an inpatient arm, an outpatient arm, and a research arm. And so we're going to try our best to kind of stabilize those that require inpatient care. We're going to try to screen for the other disorders that are associated with having the manifestation that brought your attention to a particular specialty. And then we're going to educate the practitioner that's helping you coordinate the care. So there's an opportunity to really get your symptoms under control. We don't have a cure, but we can get things under control as best we can. Yes, from one, John Furman actually said that this recording is going to be uploaded. I believe you have to go to EDS awareness website. And also I see quite a few of these talks are actually uploaded on YouTube as well. So if you just do my name and EDS awareness, or my name and mast cell, Mr. Furman was kind enough to invite me to speak before, and those talks are also uploaded on YouTube as well, but you also have the website in addition to that. There is a question about hyperflexibility while having tight muscles and little overall flexibility. Doctors comment that my joints are loose and I can bend my fingers back quite far, but I have little overall flexibility. Could this be still consistent with a connective tissue disorder? Definitely. So what happens if your joints are loose? Other parts of your body are going to try to help you. And so, including the muscles. So it's not unusual for individuals to have really tight muscles in their sternocleidomastoid and their trapezius because they're trying to make up for the looseness of the ligaments themselves. So the purpose of the screen is, do you have evidence of a connective tissue disorder? Then I would recommend using that French screen where they look to see, have you been treated for reflux? Do you have problems with sound sensitivity? Do you have problems bumping into tables? Do you bruise easily? You know, the purpose of a screen is no different than you having your blood pressure checked. And if the blood pressure is elevated, you then want to look for the reasons why the blood pressure is elevated. The same thing with the screen, either by using the Beighton screen or using the French criteria. It's to identify you have a connective tissue disorder. Now we want to figure out why and what might be traveling with it. And I would encourage you to there was a presentation that was hosted by this site called The French Perspective. And you can see how the French approach the diagnosis and management of the comorbid disorders that travel with connective tissue disorders. And interestingly enough, one of the things that have been shown to help with the tight muscles is actually using oxygen, using targeted physical therapy, and also using L-carnitine. But again, this should be under the care of a practitioner. And those are just some of the suggestions that we have seen put forth. So, and then also, not to plug a book, but just to let you know, that book, Disjointed, with the editor, Diana Jovine, God bless Miss Jovine. She actually went up to all of us at various conferences asking us to write a chapter. And for 2 years, she herded us all like cats to write the chapters, and we all volunteered our efforts. And that was just so that we can give people to have the tools to just not look at one tree, not look at one angle of what might be going on with a connective tissue disorder or mast cell dysfunction. Remember that mast cells can release lots of different chemicals that can impact the blood vessels, that can impact the integrity of the ligaments, that can call in inappropriately eosinophils or neutrophils that can cause damage on their own because they have very potent chemicals that are meant to kill bacteria and parasites, but now it's like collateral damage for like a false alarm. So I think it's, again, really important. Once you get one diagnosis, you should evaluate for the possibility of the other two that seem to travel together quite often. So I am taking new patients at the Ehlers-Danlos Center at Mount Sinai's South Nassau Community Hospital. And if you look under the name Eileen Ruhoy, R-U-H-O-Y, or Paolo Bolognese, because Dr. Ruhoy is a phenomenal neurologist and also has a PhD in environmental toxicology. And Dr. Bolognese has been working with patients that have connective tissue disorders who have compromise of the integrity of their spine for years. And now we're pooling our efforts. I am starting next week. I'm getting my ID the next week, and I should start seeing patients there starting in August. And it's by referral only, so it's really important that you have a practitioner who we can work with, help you get better. So whether you're using a medication like histamine, the question is, do you recommend adding quercetin to the regimen? Thoughts about using D-Hist that actually has bromelain, quercetin, and vitamin C as other mast cell stabilizers. I think it's not unreasonable to use quercetin or a DAO inhibitor or a D-Hist, which is that combination, but there should be a plan. If you're going to start something, whether it's a histamine, a prescribed medication, or a nutraceutical, it's important to say, I'm going to start this, I'm going to add this, am I getting better? Because taking an oral medication does not assume, or supplement does not guarantee that you're actually absorbing it, and that's going to be helpful. And it depends on what you're trying to get under control. For instance, if you have a fracture, taking a mast cell stabilizer is not going to help you heal the fracture. But if you're having migraines and you're having skin itch, or you're having irritable bowel syndromes like alternating diarrhea, gassiness, bloating, it's worthwhile to try it. If you get better, that's good news. But if you stay the same or potentially get worse, that tells me that something else is going on that needs to be identified. So have a game plan. If you're going to start something, give it the predicted amount of time, monitor for side effects, and then if that end game is reached and you're doing better, there's no harm in continuing with it. But I've seen too many people come to my practice on lots of nutraceuticals, spending hundreds of dollars monthly for these supplements, and they had an undiagnosed primary immune deficiency, or they had an undiagnosed autonomic disorder, and that wasn't getting any better. So this is a three-legged stool. And if all three legs are wobbly, taking quercetin or bromelain and vitamin C and quercetin is going after one of the wobbly legs and not addressing the other two. The next question is, do you recommend patients rotate their H1 inhibitors? On what schedule? How often to rotate? And do I have a favorite H1 inhibitor? Again, I would say it's important to understand, what are you trying to treat? So if you have mast cell dysfunction in the setting of an undiagnosed autoimmune disorder, or you have an autoimmune disorder and your mast cells are misbehaving, you have to treat the autoimmune disorder and the mast cells to get better. I don't recommend rotating them unless you find that the first time you take that medication, a hard pink color to it. I generally recommend 2 to 3 weeks of using either a first generation antihistamine such as cetirizine, which is Zyrtec, loratadine, and the trademark is Claritin, or fexofenadine, which is Allegra. And I usually recommend that in the morning. And then I recommend an older antihistamine at night, like chlorpheniramine, or which is the old chlortrimeton, as well, or Benadryl, or cyproheptadine. And again, I would just do for a couple of weeks and see if it's helpful or not, and also monitor for side effects like urinary retention or constipation or sleepiness. So if you're able to get better, that's fine. But again, if you only have mast cells misbehaving because you have quote unquote allergies, or you have mastocytosis and nothing else, then rotating your H1 blockers are fine. But I've seen, and some H1 blockers work in some people more than the others, but that's the only reason to rotate. And literally, you should be able to figure this out in no more than 4 to 6 weeks. If not getting any better, then something's being missed. And I really need to emphasize that. In the 1,000 patients that we evaluated in the past 8 years, who are coming in for suspected mast cell disorder, 40% had evidence of undiagnosed hypermobility, and another 20% had an undiagnosed deficiency with their antibodies. Like they didn't make great antibodies against strep, they didn't make great antibodies against Haemophilus influenza, which is another bacteria that people get vaccinated, children get vaccinated against. They didn't have great protection against measles, mumps, rubella, or the virus that causes chickenpox or shingles. So the biggest message I would take away from here is it a pure mast cell disorder, or are the mast cells just responding and trying to help out inappropriately? And that's the biggest thing. I have to tell you, by the time people see me, they have tried rotations of antihistamines and they're not getting any better. And by the way, histamine is one of 500 chemicals that mast cells release. You're not going after the leukotrienes, you're not going after the prostaglandins, you're not going after the serotonin. You know, so I think it's important to understand that mast cells are not a one-trick pony. It's not one thing that will cause them to release their chemicals inappropriately, and it's not just one set of chemicals that's going to be released. The next question is, have there been any studies with MCAS in patients with VCFS? I'm thinking, is this, so I'm going to type an answer. And if you can just elaborate, because I'm blanking on what this acronym stands for. So if you can just reply to me, I'm happy to address that in more detail. Is there a substitute for Chromelin sodium oral solution? Yes, there is. Depends on what you're trying to treat. If you're going for just gastrointestinal distress, understand Chromelin only works where it lands. And there has been shortages of Chromelin coming and going. It actually is available in a powder. And interestingly enough, in Germany, it's not pre-diluted. It actually is in a packet that you open up and then add to water. There's also plenty of compounding pharmacies that will put it into capsules for you, and then you can just use the capsules. It's much easier to transport, especially if you're if you are traveling. Also, understand asthma is undiagnosed. Chromelin for the lungs was one of the first treatments that was used for children that had asthma. I find that to be very helpful for people that have exercise-induced shortness of breath, or going up a flight of stairs, or having chest tightness. And then there is a nasal preparation to help with upper airway congestion or postnasal drip. There's an eye preparation for itchy eyes or tearing. And then some people will actually take that vial and put it into hypoallergenic emollients such as CeraVe or Hylotopic, and put it on the skin, and that will help keep those mast cells quiet in your skin, causing itch. But if you find, and another possibility, if Chromelin's not available, you do have Ketotifen. In this country, it's only available as an eye drop, but you can also use it. You can actually order it from Canada, where they'll send you enough for a month's supply, or you can have it compounded here in the country with a compounding pharmacy. And let me just put a word regarding compounding pharmacies. Please check with your insurance. If you're trying to get this covered by insurance, you need to check with your insurance company for them to identify a compounding pharmacy that is on their formulary, that's on their acceptable provider list. Otherwise, they're not going to cover it, and it can be very frustrating for you and the practitioner that's recommending it. So treatment for dystonia caused by mast cell activation dysfunction. So interestingly enough, I don't know if what's causing the dystonia is causing the mast cells to be upset, or there's something about the mast cells that cause problems that causes the dystonia. So a couple of things that we have been using is, and this is again, the data out of the French group, where they're using oxygen, heat, magnesium, which can also help stabilize the mast cells and the nerves. There is a medication that's used for Parkinson's, but in a much, much lower dose. But this is definitely, I have my email. I'll send my email to you, and I'll be able to send the paper to you if you like. So let me just, I'll send my email to you so you can have it. It was on the last slide as well, but as a patient with EDS and POTS and many symptoms of MCAS, what is the best way to see if I have MCAS without looking for, like, seeking a diagnosis? Yeah, there's a lot. It's getting better. My suggestion would be you can get a second opinion. There are doctors who are willing to evaluate the data that's been obtained already and review it. And interestingly enough, I can't tell you how many times I will just get endoscopy slides, contact the gastroenterologist and the pathologist and have those stained. I'll look at the tryptase, and people are told that the tryptase is normal. And again, if you have a tryptase of 7 or higher, which is actually in the normal range, there is a possibility of you having this hyperalpha-tryptasemia. But I would recommend that you get a second opinion, either from, have the practitioner that's helping you with the POTS make a referral, or the Ehlers-Danlos syndrome. And understand also, if you go to the Mastocytosis Society, it'll say find a doctor, and that will point you in the direction of a practitioner, either in hematology, oncology, or allergy immunology. And also, it's not just limited to them. There's also functional medicine practitioners, integrative medicine practitioners, although I don't consider myself a dysfunctional practitioner or a non-integrative practitioner, but I think it's really important that you already have two different things that are causing your mast cells to misbehave. You have a connective tissue that's also causing the mast cells not to be happy, and you also have a autonomic nervous system issue that also can talk to the mast cells. For instance, I have cold-induced hives. I can tell you, if I get cold, it's not an antibody to the cold, it's the nerves saying something's changing that's not good for you, and tell the mast cells to degranulate inappropriately. So I think if you optimize the treatment of the EDS and the POTS, and also confirm the diagnosis of mast cell activation disorder by going to a practitioner, and literally they can just evaluate it. And there's actually a wonderful article, I'll put it in here for you. It's by Matthew Hamilton. Saying, it's pretty innocent, the medications that we use to treat for it, but just because it's innocent doesn't mean that's the course you should be doing for the next 20 years. Growing body of evidence supporting non-clonal mast cell activation syndrome, which is what we think is typically happening in an individual that has the Ehlers-Danlos syndrome and the POTS. So, oh, wow. So interesting. Thank you. So DeGeorge, so anything that causes structural abnormalities, you can have mast cell dysfunction. It's interesting on what's causing DeGeorge, which can happen at lots of different levels. But I can tell you, we have patients who have other genetic connective tissue disorders. We have a patient who had exposure to DES in utero, and that caused her to have structural facial abnormalities and uterine abnormalities. And that was associated with her having antibody issues, mast cell dysfunction. You know, it's understand mast cells talk with all different cells. They talk to the epithelium, they talk to the nerves talk to them. And yes, that can cause mast cell dysfunction. So I think it would be really important to, and by the way, the one thing that seems to run in individuals that have connective tissue disorders, their antibody levels have a tendency to be lower than the normal non-hypermobile population. So mast cells are definitely misbehaving. It might be the genetic disorder that predisposed to DeGeorge, or it can be other comorbid disorders that run with the VCFS that is leading to mast cell disruption. So in order for the mast cells to come under control, you need to address what's poking the mast cells to be misbehaving cell population. And again, they can release lots of different chemicals. And so you just don't want to go after the chemicals. You want to figure out what's triggering them to release those medications, those chemical mediators. The next question is, what would you recommend for someone who has hyperalpha-tryptacemia, which is HAT, confirmed by genetic testing in HEDS as well as POTS? I'm on Xolair presently and taking H1 blocker, H2 blocker, leukotriene blockers, but still have GI issues with some skin itch and postnasal drip, and Cromolyn PO doesn't work. So a couple of things is you need to make sure your POTS is well controlled. And you should also be evaluated for whether or not you're having proprioceptive issues, like balance issues, and making sure you don't have any cervical spine issues. So we find individuals that have the HEDS and the POTS, they also may have issues with their cervical spine causing their vagus nerve to misbehave. And if the vagus gets impinged, then you'll end up having more mast cell activation. So controlling you're kind of maxed out on trying to control the mast cells, but that's kind of like having a police officer who sees a crime, he thinks or she thinks sees a crime being committed, but you don't see it and you're trying to restrain them. So taking all these medications, you're restraining the mast cells, but the mast cells are still saying there's other things you haven't addressed and you need to address those issues. And so I have patients, I have to tell you, I have patients on IVIG at doses for primary immune deficiency. Some are on levels for the immune-mediated neuropathies. We're doing targeted physical therapy with knowledgeable patients, knowledgeable physical therapists who are addressing the pain points. There are medications that also target the POTS. And also, I would make sure that your gut is working appropriately, because we find with POTS, a lot of patients, both kids and adults, will have what's called postprandial hypotension. Like every time you eat, the blood flow just causes more fatigue, and having more fatigue means less energy for your muscles to keep your joints set. And with your joints having more instability, another danger signal goes out. So it really is a vicious cycle that needs to be interrupted. So I would say make sure that your musculoskeletal issues with your HEDS have been optimized diagnosis and management wise, and that also the etiology of your POTS. Is it truly just a connective tissue issue, or is there something else going on? And then the and understand that there's some really good lectures with both the Ehlers-Danlos Society, who does talks about postural orthostatic tachycardia syndrome, and I believe, John Furman, you can correct me, Peter Rowe has actually given some really good lectures talking about how mast cell activation syndrome interacts with postural orthostatic tachycardia syndrome. Brent Goodman has also done this. There are a lot. Again, you have to go after each leg of the stool. Connective tissue is doing well. The mast cells are doing well, especially in the GI tract, so it's not vitamin C deficient because their gut isn't working well. And so sometimes you have to supplement, not using the gut, but actually going through the, doing intravenous vitamin supplementation until we make sure your gut's working better as well. So it's a coordinated effort. I would have to say the core teams that I have worked with is an individual, so I do a telehealth practice for individuals as a second opinion with Isabel Brock, who is one of the experts from the French EDS group, who's now evaluating patients, making suggestions from her observations from the French group. That's the clinical paradigm. So if you go to clinicalparadigms.com, you'll read about her efforts. And then also a fabulous nutritionist that I work with, Dr. Jessica Pisano, again, who works with Pilates instructor and assistants who help with the environment modification as well. So again, it's a coordinated effort. I apologize for the long-winded answer, but it really needs a team to help you feel better. What might be the next step for a patient with MCAS who is regularly having anaphylactic reactions, who's unable to take any meds by mouth? You also can't take Xolair. Okay, so the first step would be, I have to tell you, I've had 4 patients in the past year who had recurrent anaphylaxis, not only to Xolair, but to Dupixent, to medications going after hereditary angioedema. And that's because a lot of these injectable medications have a stabilizer in there, either polyethylene glycol or polysorbate, which might be problematic. And interestingly enough, they all had an undiagnosed immunodeficiency, like their IgG level was 2 standard deviations below the mean. And we've been able to get them under control with a combination therapy of a desensitization protocol using either antimicrobials, gamma globulin. We're using acupuncture, acupressure, oxygen, everything to kind of stabilize the different major players that causing the mast cells to be disruptive. So in many ways, it sounds like I would take a step back and try to understand what your mast cells are seeing that's causing them to be released. And I have to tell you, the one thing that has been the new research or the new train of thought that's happening in the allergy immunology world is the connective tissue controlling whether or not mast cells will degranulate. So there was a very interesting observation a few years ago where if I, for instance, went out and tested 100 people randomly for IgE to peanut, I would easily find anywhere from 13 to 15 people with a positive reaction to peanut, IgE-wise. Then you ask those 15 people with a positive IgE to peanut, do you have problems with peanut allergy? And only 5 do. So now the way allergy immunology specialists are thinking is, what is causing the mast cells to misbehave in the 5 that have reactions, and what's causing them to stand down in the 10 that don't? And it seems to be, if you go after the connective tissue and get it to be happier, then the mast cells are less likely to be called into action. And some of the agents that have kind of gone into this world is an agent called TSLP for short. But it sounds like I think you need a further idea of understanding why your mast cell is misbehaving. Do you have a clonal mast cell disorder, like an undiagnosed systemic mastocytosis or an undiagnosed variant called monoclonal mass activation syndrome? Or do you have hyperalpha-tryptocemia? Or do you have an undiagnosed comorbid disorders causing your mast cells to misbehave? Because again, if you're just trying to control the mast cells and the mast cells are trying to help you out with something that you're not seeing, you're not going to get any better. Very interesting question about mast cells talking to fat cells called adipocytes. Yes, mast cells can cause adipocytes. There's limited data, but it's showing that it depends on what chemicals are being released. I have seen individuals that have painful lipomas called Derkham's disease. And interestingly enough, if you can kind of go after the lipomas with some interventions as well as control the mast cells, you can stop that forward communication causing the adipose to get worse. It also possibly is contributing to metabolic resistance as well, insulin resistance. So there's interesting conversation going on right now on how can we help. Some individuals can't lose the weight, and it seems to be this, again, crosstalk between the mast cells that are in a stressful state, talking to all the connective tissue, including lipomas. Can I speak to hyperalpha-tryptocemia more generally? So if you just have hyperalpha-tryptocemia, then you can use, and you're symptomatic, and understand it's an autosomal dominant disease. So they actually, in the studies, they actually identify 3 generations. And if you talk to all the members that have the positive gene test, they would say, I have a little bit of this, a little bit of that, but I'm not as bad as the person who allowed this family to be identified for this study. So it all depends on what your symptoms are. Sometimes it's organ specific. For instance, are you having joint laxity or bruising issues? Or are you having hypersensitivity issues like irritable bowel or skin itch or brain fog? There are going to be different treatments depending on which organ is involved. And interestingly enough, a lot of it falls back to, actually, if I can share again, let me see if I can. Let me get this rolling again. So if you just have broken mast cells with the hyperalpha-tryptocemia, using these treatments should be helpful. But I have to tell you, one paper that I just read, the person had hyperalpha-tryptocemia, had IgE to stinging insects, had autoimmune disorder with antibodies against the thyroid, so was diagnosed with Hashimoto's disease. So in order for that person to get under better control, you had to use these medications, but you also had to go after the thyroid disorder. And you also had to address the immunodeficiency with vaccines. So just having hyperalpha-tryptocemia does not exclude you from other things happening outside of the mast cell causing you to have problems. But usually this is the first line of treatment in this column that says the allergen-specific IgE, but this is also relevant for individuals that have chronic hives, who have irritable bowel syndrome. Actually, a really good study out of France showed that omalizumab was very effective for individuals with lots of different types of mast cell disorders, including hyperalpha-tryptocemia. More studies to come, but I would start with these first, including addressing diet, usual suspects. And a lot of people ask me about a histamine diet. I have to tell you, I don't know what that is. There's so many variations on the theme. I happen to follow the recommendations of either 6 or 8 elimination diet. And if you're going to eliminate, you definitely should be working with nutritionists, because if you eliminate and try to reintroduce, you want to make sure that you didn't lose your tolerance. But the top 8 typically is gluten, tree nuts, peanuts, soy, shellfish, fish. It's easier to tell you what you can eat. It's like old world grains, fruits and vegetables as you tolerate, poultry, staying away from leftovers, staying away from fermented products. What am I forgetting? Soy, gluten, wheat, eggs. Some people do better with egg yolks as opposed to egg whites. And then if you're going to do that elimination diet, this is the avoidance measure. You don't want to stay on that diet. You want to start introducing things back in to see whether or not there's one offender more than the other. You have a host of different medications. Generally speaking, the leukotriene blockers, there are 3 out there. I would try that for at least 2 weeks to see what, because it usually takes about a week for the leukotriene blockers to make a difference. Tricyclic agents, I have to tell you, I use those quite a bit. They've been around a long time. The doses that we use are much lower than what psychiatrists use for mood disorders. And it's funny talking to the older psychiatrists or more seasoned psychiatrists. They are big fans of like doxepin and nortriptyline and amitriptyline. You have the mast cell stabilizers in the form of chromin and catodafin. Immunotherapy, you definitely need to work with an allergy immunology specialist. And there's both shot immunotherapy and sublingual immunotherapy. And actually, there's a very interesting woman who was part of the Jaffe Foodology Institute. Her name is Xiumin Li, so XIU-MIN Li, who has really good data using traditional Chinese herbal therapy and acupuncture, acupressure. As a matter of fact, she's at New York Medical College, and they are going to be having an East-West conference talking about the use of traditional Chinese herbal therapy to help with hypersensitivity disorders like this as well. And there's more data coming out using Dupixent, which is the dupilumab. So PRP is interesting. It's kind of hit or miss. I don't know if I can make a general recommendation to say it's safe everywhere, because I've had patients have adverse reactions, and I don't know if it's the PRP or the other substances that they inject when they do the PRP. So it might be worthwhile to talk with an allergy immunology specialist to see, you know, would it be better if you use a different type of a steroid that they might be injecting, or anesthetic, maybe a little bit more better tolerated, or whether you should be pre-medicated before you get the PRP. So it really is important to have a game plan when you're having a procedure, whether you're going to get a CAT scan or you're going to get a steroid injection or PRP to see whether or not that's helpful. I don't know. PRP isn't necessarily used for mast cell per se. It's actually used for individuals that have joint issues where the mast cells are known to misbehave. Is there a relationship between mast cell activation disorder and small fiber neuropathy? It's been reported. I think there's a stronger association with mast cell activation disorders and orthostatic intolerance and POTS. Small fiber neuropathy in many ways is like a trash can diagnosis. You're having these symptoms, they check to see if the nerves are gone, but it doesn't tell us why. And a lot of the data that they use to treat it, I've not seen small fiber neuropathy improve with use of any of these medications, except for in a select few with high doses of IVIG. And typically what they do is not only do you have small fiber neuropathy, you have evidence of autoantibodies that are targeted to the nerves. And I have to say, I've seen people get better going after why they have the mast cell activation disorder and the small fiber neuropathy. This is actually small fiber neuropathy where the nerves are getting injured, can be happening because of joint instability and the shearing stress that's happening in the impacted connective tissue. So it would be important to see whether you have a connective tissue disorder. I hate to label you with something, with another alphabet soup diagnosis, but typically if you're having mast cell dysfunction, it just tells me your mast cells are misbehaving, not why. If your small fibers are gone, it just tells me you're gone, but not why. But I have to tell you, mast cells and small fiber talk all the time. And so whatever is bothering the mast cells might be bothering the nerves and vice versa. I definitely also, the small fiber neuropathy, you also want to make sure you're not having any cervical spine issues, which can cause the vagus nerve to be upset, which then can impact the downstream nerves as well. Will you be seeing people that just for MCAS? Actually, so the question is, will I be seeing people just for mast activation disorders? No. I will be rounding with Dr. Bolognese and Dr. Ruhoy. I would like to see the patients before they have a surgery to make sure whatever's done during the surgery is best tolerated, making sure that there's no evidence of hypersensitivity, making sure there's no evidence of immunodeficiency. And then there are individuals who just have mast cell dysfunction and don't know that they have these another comorbid disorder. So I'm going to be seeing all comers as long as it's being referred by a practitioner who will be able to work on the team, because I'm essentially going to be acting as a consultant to you or the patient and the practitioner that referred the person refer the person to the practice for evaluation. Okay, I have a couple more questions, and then you have to excuse me, I'm going to have to go in a little bit. So I mentioned that mast cells talk to all kinds of cells. How do mast cells relate to estrogen? Do they impact or contribute to estrogen dominance and the myriad of associated symptoms? Yes. Actually, if I can go back, I apologize for the rapid rollback. So mast cells have estrogen receptors and androgen receptors. So we know for women, when they start their menses, which is what happened with Sarah, she started her menses and got an infection. That's when the door opened up to her gastrointestinal distress and fatigue. We also know that women that have asthma or urticaria going in or out of their menstrual cycle can cause mast cells to misbehave more. And we also know that women who go from, start becoming perimenopausal will also, again, it's a change. So if mast cells detect a change and they see the estrogen, and there are other things that are causing the mast cells to misbehave, the increase or decrease of the estrogen can make things worse. So yes, there's a strong association between estrogen and androgen and causing mast cell dysfunction or exacerbating mast cells. And in actually some cases, we see, for instance, with women who during pregnancy, their symptoms become infinitely under better control. So it all depends on the background of which these mast cells are operating. So there's a question about the number from Mount Sinai not working. I do believe that there is an email that can be reached. I will provide that information to Mr. Furman so that it can be listed. I have to tell you, I literally have not started yet. I just got my exam and, fitting. I will be out there for EMR training in the next 2 weeks, and but I know that that information is going to be reposted. They're working on the website also, so that should be forthcoming no later than the end of July, early August. And so the question is, am I willing to do remote patients via video appointments? I'm able to do so because I'm licensed in New York and Maryland. I can evaluate patients via telehealth with the patient contacting clinicalparadigms.com. We're still working out the policy, but I do believe telehealth appointments will be available only with a practitioner has to agree that they are going to be responsible for the data that's discussed during the meeting. So there are two options right now, either through clinical paradigms or waiting for the powers that be at Mount Sinai South Nassau to coordinate remote visits, telehealth visits. So the question, hey, the question is, any recommendations on how to find a good gastroenterologist or GI specialist who might know Ehlers-Danlos syndrome, partial orthostatic tachycardia syndrome, mast cell activation syndrome? Yes. So you're going to want to look for individuals that specialize in neurogastroenterology. So one person who is excellent is Laura Pace, who's at Utah. There's John Fortunato, who is at in Chicago. There is, I'm blanking on their name, but honestly, I would look at, I would just punch in to neurogastroenterology, and you can just do mast cell and Ehlers-Danlos, and you should be able to pull up some data. The paper that was the lead author in the American Journal of Medical Genetics, the lead author was a woman named Dr. Fikri, who's out of the United Kingdom, and they actually just had a huge neurogastroenterology conference. This is an emerging field, subspecialty in gastroenterology, but I would start there. But Laura Pace has done some wonderful videos on the role of mast cell dysfunction, POTS, and Ehlers-Danlos for Dysautonomia International and also for the Ehlers-Danlos Society. And so has Dr. Fortunato. Interestingly enough, there is no adult EDS clinic, but there are 2 pediatric EDS clinics in the country. There's one at Mercy Children's in Kansas City, and the other is at Denver Children's. So if you so both of those institutions would be helpful. And then there are gastroenterologists who are just willing to learn. So again, I would almost encourage you to find a gastroenterologist who's willing and able to learn with you, and willing to work with the other specialists who show a little bit more experience and expertise in that field. So the question is whether or not the clinic at Mount Sinai Staff Not-So accepts insurance. Currently, I know that we do accept Medicare, and each one of us has different insurances that we participate in. That hasn't been fully worked out, but each one of us has. I'm on at least 5 policies. And I think they're going to try to work out an arrangement. It all depends on also working out non-participation. I apologize, but I'm still learning the details of this practice because I just signed on 6 weeks ago and just started getting information on the logistics of the practice. So the final question is, daughter has an upcoming endoscopy. Is there anything we should ask the gastroenterologist to include to test for mast cell activation syndrome, other than asking them to stain for mast cells that you mentioned in the talk? And so I'm going to write out the stains that they should look for. So the stains for mast cells, it's called CD117. That's to look for mast cells. And then the question is, are the mast cells round versus spindle shaped? How many are there? So generally speaking, more than 20 to 25 mast cells, but they're still working on the data per high power field. And then also, did they upregulate any activation markers? Such as CD25. So sometimes they need to stain for both the activation marker CD25 as well as CD117. So that's helpful. And then, I always, if you're going in and they're getting blood work, I'd always check a serum tryptase going in. So you have another measurement. And then if hopefully, the 24-hour urine collections for methylhistamine, prostaglandins, and leukotrienes have already been measured. So anyway, everybody, you've been wonderful, great questions. I hope that you found this helpful. Mr. Furman, again, I thank you for the opportunity to talk about a cell population that I actually had to learn about because I was a T-cell biologist by training, but it really has opened up a whole new world on how our bodies are reacting to an ever-changing environment.
Well, we certainly appreciate all the information that you provided. It's been really overwhelming in a way. And so we do have it recorded, and it will be posted on the link that those that registered for the program will be on there. We will also have the slides available on that site. And we will send out an email for those that registered and also to our email listing so that people have access to this. It will also be on our webinar page along with the other 3 webinars that Dr. Maitland has provided to us. So we're really excited about your new opportunity, and we're excited about the new information that we're receiving about mast cell activation. So all the best with your new program. Keep us posted. We'll keep the information on our website and keep it updated so that people can contact you and can have access to the information that you're providing. So we're really excited. Thank you very much, Dr. Maitland, for this extremely helpful program.
No, my pleasure. My pleasure. I want to wish everybody good health. Please get vaccinated. And I look forward to meeting some of you when the doors are finally open for me at Mount Sinai South Mast Hill Community Hospital.
Okay.
Stay safe.
Take care. Take care. Have a good day. Take care.
Okay. Bye now. Thank you.